workshop for nurses. And the first speaker is Sandra Kurtin. She is in the United States of America in Zoom. And she will have 20 minutes to make the speak.
We can see you, Sandy.
All right. Very sorry I couldn't be there in person. I'm missing all of you, but glad I can join you virtually. So my role today is to talk about the revised classification and stratification of MDS.
We can see you and hear you, but we don't see your slides.
Yes.
Okay, they somehow are. Let me try and share my screen. Sorry.
That's all right.
Zoomers want to call.
We're
Okay, let's try to get through this. So I'm going to just very briefly go over MDS as a disease state, and then we'll really talk about the new nomenclature, which is getting more and more complicated. So as you know, Alagille syndromes are a group or a spectrum of clonal hematopoietic stem cell malignancies, myeloid. The key features are dysplastic changes, which lead to ineffective hematopoiesis, and ultimately peripheral cytopenias. These diseases are characterized by recurrent cytogenetic and molecular abnormalities, and this is becoming really at the core of how we risk stratify these diseases. We always worry about leukemic transformation, and so that prognostic scoring system is really based on the risk of leukemic transformation as well as survival. And over time, the bone marrow function just deteriorates. Now, in the United States, we use SEER data, and for the United States, I think the important thing here is that this science is relatively new, and we are all still learning, and so much is happening. It's a great thing, but understanding that the numbers that we have really do not adequately reflect the impact that this disease has across populations. We know that largely it's underestimated as we have an aging population, that we are becoming more sophisticated in our ability to recognize the disease. So hematopathologists are learning along with all of us in how to recognize these diseases morphologically and then how to categorize them. As we are doing bone marrow biopsies and asking questions about the bone marrow sample, including cytogenetic and molecular abnormalities, we're better able to identify these diseases that may have obscure dysplastic changes just by morphology. So a lot has happened in our ability to recognize the disease. And then we know that, unfortunately, we are seeing many more cases of treatment-related MDS and AML in individuals who've been treated for other malignancies. So unfortunately, that group continues to rise. So when we make the differential diagnosis, we very, very important, and I'm going to touch just briefly on this, look at comorbidities, performance status. We really now talk more about frailty. And then what is the history of cytopenia? So I see both malignant and benign hematology patients in my practice, and we get patients who have low counts or high counts, and it's really important to look at how long has that been going on. It may help us understand when they may have developed MDS in those lower risk patients, and that's going to help us understand their disease course over time. And then ultimately, we're going to look at peripheral blood, but you need a bone marrow biopsy to make the diagnosis. So if you see a patient and they say, I have MDS, and they've never really had a bone marrow biopsy, that's really not adequate for diagnosis. And as we go through this classification change, it becomes very clear, at least to me, about why that's necessary. So we used to have this World Health Organization nomenclature, and this was the 2016 version that actually didn't come out till closer to 2018. And it really talked about dysplasia and the percent of dysplasia needing to be in 10% or greater cells. But this was complicated when it came out. And we had this relatively short list, however, of disease groups. And then it also was important because CMML, which was in with MDS and then out of the MDS nomenclature, was back in and really recognizing the MDS-MPN crossover disease. And there's actually a workshop going on right now looking at just how we have learned to fully characterize that subgroup of patients. And then comes very recently in the fall of last year, the updated nomenclature. And this was really to, years ago, we went from myeloproliferative disorders to myeloproliferative neoplasms to really say this is cancer. And in MDS, I think the push was the same. There are still people who today will say, oh, it's just a blood disorder. No, it is cancer. This is a group of malignancies. And as we go through the nomenclature, when we talk about molecular and cytogenetic abnormalities, that is a part of the definition of a neoplasm or cancer. So really, this is the push in part. And then really defining these diseases by those genetic abnormalities in addition to morphology. And morphology still plays a critical role, but sometimes you don't meet that greater than 10% threshold, and yet by these newer genetic abnormalities that indeed this meets the criteria for MDS. So this is basically that nomenclature, and looking at how we are defining this. And I think the important thing for all of us is how do we help our patients and ourselves crosswalk what you had and what you have now in the new naming system. It's going to be critically important to help the patient understand that it just is part of a refinement of the science. So the first thing is MDS with defining genetic abnormalities, and we're still going to look at the blast percentage, so that is still important, but much more focus now on cytogenetics and the presence or absence of mutations. So we're going to talk about MDS with low blasts and isolated 5q deletion. So the MDS with an isolated 5q deletion has always been part of the nomenclature, and largely because that group does better. But you see less than 5% bone marrow blasts and less than 2% peripheral blood blasts. And then that 5q deletion alone. And one other abnormality can be included in there, but you can't have any abnormality of chromosome 7, which by itself has adverse outcomes. And then MDS with low blast and SF3B1 mutation, and that's now named MDS SF3B1. And again, you're going to have some exclusion criteria in the cytogenetic setting there.
and then that having to have the SF3B1. SF3B1 by definition is associated with ring sideroblasts. So the criteria here is greater than 15%. Ring sideroblasts may substitute for SF3B1 just because those two things are linked. And then you have this MDS with biallelic TP53. TP53 by definition is a poor prognostic indicator. TP53 is your surveillance gene. When that is mutated, your body can't adequately do that. And so these patients tend to have disease that's more difficult to treat. And so basically that is the definition there. And then there is MDS morphologically defined. So we have MDS with low blasts, just what it sounds like. MDS that is hypoplastic. These are those patients that we have talked about being hypocellular, often is some immune component to their disease. And then MDS with increased blasts. So we had, you know, RAAB, RAB1, RAB2. This is sort of replacing that, simply based on the percentage of blasts. So how does that, what does that mean for a patient and for us? So when we look at MDS genetically defined, MDS low blast and isolated 5q, we've had MDS del 5q. So that's a pretty simple crosswalk. MDS with low blast SF3B1 is crosswalk to the MDS with ring sideroblasts. MDS with biallelic TP53 has no comparator in the current system. And then when we do the morphology, we had MDS with single lineage dysplasia, MDS with multi-lineage dysplasia, and that's gonna crosswalk into this MDS low blast. And then the hypoplastic really didn't have a name, but now it is named in this new system. And then, as I mentioned, the excess blast 1, excess blast 2, there's a new MDS with fibrosis. And so this is emerging out of that MDS-MPN crossover nomenclature. And then AML is now defined as still 20% bone marrow blasts, or in the new system, this international consensus group, greater than 20% bone marrow blasts or greater than 10% with defining molecular abnormalities. And this is why that matters. So this is the IPSSR, which we've had for quite some time now. And you can see just based on taking the characteristics with cytogenetics, blasts, you know, our cytopenias and depth of cytopenia, and giving each of those a score, someone with very low risk disease has a median or mean overall survival of 8.7 years. Someone with very high risk disease has less than a year to live. We're gonna approach those patients in a very different way in terms of very high risk, poor, and very high. We need to start treatment right away. They're more likely to die of leukemic transformation, whereas somebody with very low risk disease is not going to die of leukemic transformation, and we may be able to monitor them without treatment for some time. Now we have the IPSS-M, and there's a lot of information at the meeting about all of this amazing work. And so it's taking into consideration IPSSR, but now we're going to do our next-gen sequencing and look at these driver mutations and categorize them as very low, low, moderate, high, high, and very high. And this is just a graph. If you start in the upper left-hand corner, the worst prognosis, so that TP53 that I just talked about, and now look at SF3B1 plus del5q, that is not favorable. So del5q by itself is a cytogenetic abnormality that is favorable, but when you add it to SF3B1, it is not favorable. And then all the way over to the lower right-hand corner is where you see SF3B1 by itself as more favorable. So understanding these molecular attributes is important. I think, thankfully, we have an app, and it was just released on the phone, it's been available online, but there is an IPSSM calculator. And basically what it's going to do is give you the same information, the risk of AML transformation and death without AML, as well as leukemia-free survival and median overall survival by subgroup, just based on that molecular profile. And so this is roughly 2,700 patients that met criteria to have their samples included in this work. The number of cases sent were far greater, but missing information basically, and were not included in this final analysis. So you can see the big difference here in terms of median leukemic-free survival, for instance, in very low 9.7 years, very high 8 months. So not unlike the IPSSR in that way. And so those two things very nicely correlated in terms of those expectations. And then time from MDS diagnosis and death without AML, again, looking historically back at counts and trying to estimate that. But if you even just have a newly diagnosed patient, you're going to have a big difference in 15.9% death without AML, in the very low risk, 51% in the very high, but then go up and look at AML transformation, 2.8% at 4 years and very low, as opposed to almost 43% and very high. So again, high-risk patients transformed to leukemia tends to be their cause of death. Low-risk patients, not likely. They're going to have other factors. And some of those other factors are frailty and comorbidities. And so this is a great paper that really speaks to this, to say, outside of all the things we just talked about, if you just look at frailty and comorbidities, that has implications in terms of overall survival. So this is 1 year overall survival in clinical frailty, either greater than 5 or less than 5, and Charlson Comorbidity Index, either greater than 2 or less than 2. And you can see the big difference just in that percentage of 1 year overall survival in those two groups, where the people who are less frail, have fewer comorbidities, do significantly better than those who have greater comorbidities and are more frail. And then the other thing I think that is still relevant today, this is a paper that looks at just transfusion dependence, which really is telling us that that bone marrow is not working. And it's really important to understand transfusion dependence in terms of a negative prognostic factor in MDS patients. So this is, and we know that roughly 90% of patients with MDS become red blood cell transfusion dependent over the course of their disease. This has implications for quality of life, tethering them to the treatment centers, so that time spent on transfusions, and then all the things that come with chronic transfusion alloimmunization, transfusion reactions, iron overload, and then other more rare transfusion-related complications. And I'll stop there and see if there are any questions.
Thank you very much, Mrs. Kurtin, for your nice presentation. It's not easy to present all new classification, very complex. Do you have a question?
Thank you.
Sandy?
All right.
Sandy,
Yeah.
it's Erin. It's good to see you, but not see you here. Very sad.
I know, I'm so sorry.
Awesome presentation so far. I just downloaded the IPSSM calculator, so I don't have any feedback, but it's right now. I want to use it in real time in the clinic, because I think this is your presentation thus far, showing all the changes that are happening all at the same time is very overwhelming, not only for nurses, but for patients, and what does it mean? So I think these new tools are going to be amazing for all clinicians in the clinic.
Yes, I really encourage everybody to download them, and it also includes the data from IPSSR. I will tell you that I have updated the building blocks of hope to include this information for patients, but it's hard to make it simple because it's not.
Right.
So as much as we all just keep seeing it and internalizing it, and I'm sure you'll hear a lot more, we'll hear a lot more at the meeting this week. So thank you, everyone. I'm going to mute myself.
Thank you. So let's move to the next presentation about management of the patient with lower risk MDS by Dr. Comont.
Hi, welcome everyone. First, thank the organization to suggesting this topic, and thanks to Professor Rosie to suggest my name for this topic. So it's difficult. I don't know who are you, where you work, and what's your level. Maybe you are better than me for this topic, but so don't hesitate to correct if I'm wrong. So we're going to talk about management of patients with low risk MDS. My name is Thibault Comont. I'm working in Toulouse, in southwest of France. Here are my disclosures. So I think we can redefine what is a low-risk MDS. And as you saw just before, we use the IPSSR score, which include bone marrow blast, cytopenia, and cytogenetic features. And an IPSSR score less than 3.5 defines what is actually a low-risk MDS, which means these patients have low risk to develop an acute myeloid leukemia during their story. That's all. But low-risk MDS doesn't mean this is a low-risk disease, because these patients can suffer from some complications related to cytopenia. And the first of this cytopenia is anemia, which is the most frequent cytopenia in low-risk MDS patients. And we know that anemia is an independent factor of mortality in these patients, but also decompensation of comorbidity and impaired quality of life. These patients can also present with thrombocytopenia, and therefore with severe bleeding. Also neutropenia, and may develop severe bacterial infections, but also invasive fungal infection. And finally, we know that low-risk MDS are associated with autoimmune manifestations. But first talk about anemia. And as I say, in these patients, anemia is an enemy. We know that quality of life is strongly correlated to hemoglobin levels, but also there is strong correlation between transfusion and overall survival. So how we manage these patients with anemia? First situation is the wait-and-see situation, when patients have non-significant anemia or any symptoms. But most of them have severe anemia requiring transfusion and are symptomatic. And the first treatment in this situation is EPO. It has a response rate between 50 and 70%, with a median duration of response of 2 years. We know that patients have a better overall survival if they respond to EPO, and the story of the disease is better if we initiate early EPO. We have some options to choose, but we can use, for example, epoetin alpha, first weekly, but also twice weekly, or darbepoetin, at first 1 injection per 3 weeks, and then weekly. But most of patients present primary or secondary failure of EPO. And the next line depends on the patient and MDS characteristics. First situation is when patients have MDS del5Q, which means they presented with isolated del5Q on the karyotype. In this situation, the gold standard is lenalidomide. It's an oral treatment given at 10 milligrams per day during 21 days in a month, with a break of one week. It allows 65% 5% of transfusion independency, 50% of complete cytogenetic response, with a median duration of response of 2 years. We have to be careful because at the initiation of the treatment, patient can present increased severity of cytopenia that's requiring close monitoring. The second situation is a patient with ring sideroblast MDS, which can be associated or not with SF3B1 mutation. In this situation, luspatercept has been recently approved. As you maybe know, luspatercept is a trap ligand molecule that binds to several TGF-beta superfamily ligands, leading to restore normal erythropoiesis and increase the number of mature red blood cells. The most important trial, the phase 3 medalist trial, show in this trial, close to 40% of patients treated by luspatercept achieved the primary endpoint of RBC transfusion independency for 8 weeks or more, comparing to the patients receiving placebo, which had 13%. I think I can, no, it's not like that. I can show you, but okay. So 40% comparing to 13%. This is a treatment administered by a subcutaneous way at home with 3 dose level steps. 1 milligram per kilo, 1.33, 1.75. And we can move to the upper dose after failure of 2 injections at the primary dose. In medalist, luspatercept show also an improvement in quality of life in these patients. But we saw some side effects, especially asthenia, various pains or tachycardia that are not related to anemia. And it's important to know that, because patients presented with this symptom, and sometimes these symptoms are stronger than they have before we start the treatment. So it's important to keep in mind. The third situation is when patients don't have del(5q) MDS or don't have MDS with ring sideroblast. And in this situation, we could have some options. When patients have hypocellular bone marrow, we can use immunosuppressive therapy as ATG or cyclosporine. Lenalidomide can be used in these patients, but with lower rate of response. In US, but not in Europe, hypomethylating agents as azacitidine or decitabine are approved in low-risk MDS with cytopenia. When the patients are young, and especially when we found a natural donor, we can consider hematopoietic stem cell transplantations. And it's exciting that new drugs are arriving and could be soon approved. First, we can target mutations, and especially IDH mutation, which are present in about 10% of patients with MDS. And in 2 clinical trials, the French group of myelodysplasia show efficacy of using IDH1 inhibitor or IDH2 inhibitors in patients with low-risk MDS and refractory anemia. I can talk about 2 other interesting drugs, imetelstat, which is a telomerase inhibitor, or roxadustat, which is an epoxy-inductive factor hydroxylase inhibitor. Both shown very interesting results in phase 2, and we are waiting for the result of the phase 3. But it could be approved in a few years, I think. Next, the major concern in this patient and in patients with repeated transfusion is iron overload. It is an independent factor of mortality in this patient, and you can see on the graph that the level of ferritin is strongly correlated to the overall survival. So first, we can evaluate the impact of iron overload by MRI, especially on the liver or on the heart. But in practice, we start treatment in patients with received more than 20 RBC packs, or when the ferritin level is higher than 1,000 micrograms per liter. 3 molecules are available, but the deferoxazirox is the first-line therapy. It is an oral treatment given daily. And we just have to be cautious with the side effects, especially gastrointestinal symptoms, as pains or diarrhea, especially at the initiation of the treatment. When patients can't receive deferoxazirox, for example, in case of renal insufficiency, we can use other chelator treatment as deferoxamine, which is given subcutaneous at home, or deferiprone, which is another oral treatment. So about patients with thrombocytopenia, I said before that low-risk MDS patient can present with severe thrombocytopenia. The question is, what is severe thrombocytopenia? And we really don't know. We put some cutoff to the platelet level, and we can say maybe a severe thrombocytopenia in patient is a platelet count maybe under less than 20 or 10, and in patients with anticoagulant therapy, it's maybe less than 50,000. But in this patient, so you can use transfusion, but you can also use treatment, and especially TPO receptor agonist treatment. 2 molecules are available, L-Thrombopag, which is a daily oral treatment, and Romiplastim, which is a weekly subcutaneous treatment. The efficiency is similar between both, and you can switch from one to another in case of inefficacy of one. We have to be careful with the risk of thrombosis with this treatment, especially in patients with MDS, because they often are old and they have a lot of cardiovascular comorbidity, which increase the risk of thrombotic event. Finally, I said before that MDS or CMML are associated with systemic autoimmune and inflammatory disease, approximately 20% of patients. Steroids or biologics are currently used, but the French group of myelodysplasia shown before that azacitidine, which is a treatment for high-risk MDS, has a good response in this kind of patient with a response rate more than 60% of patients. And it's very exciting because we know that a part of these patients have, in fact, a new disease called VEXAS. It's an acronym for vacuole iron enzyme X-linked autoinflammatory somatic. This is a new disease first described in 2020, leading to a large autoinflammatory and autoimmune manifestation, and due to UBA1 mutation gene. And there is a strong correlation between low-risk MDS and this disease. So some patients with MDS with inflammatory symptoms have, in fact, MDS with a VEXAS. The pathophysiology of this disease is still misunderstood, but we know that the prognosis is poor, and the treatment is a real concern for this patient. The French group of myelodysplastic syndrome and the French VEXAS study group showed very interesting results with azacitidine in this setting, but also with JAK inhibitors as ruxolitinib And in case of refractory symptom, or in case of higher risk MDS, we can consider hematopoietic stem cell transplantation. So in conclusion, EPO is still the reference treatment for low-risk MDS, but new drugs are arriving and maybe can be approved soon and maybe in future, plus just before EPO. I think that, as usual, the important thing is to identify who going to respond to each treatment with the most acceptable safety profile. So thank you.
Thank you very much, Thibault, for your presentation. Do you have a question in the room? No question.
No question on the computer.
So I have one question. Do you think is luspatercept a revolution, a therapeutic revolution? And could you tell us some words about the duration of the response to luspatercept?
I think it's not a revolution. It could be, but I think there are two concerns. The duration of response, I think it's maximum 2 years, I think, something like that. And in 2 years, a lot of patients lost their response. And I think we have to consider the side effects. And we saw in real life, I think, more side effects than in the medalist study. And I have some patients that who stopped the treatment because of side effects, but they are in response, but because of side effects. So I think it's not a revolution.
Thank you very much. What do you see as the most common side effect with the luspatercept?
Fatigue.
Fatigue.
Yeah. I have some patients who are more bad on luspatercept than before, but they have an hemoglobin level higher than 10, right. But they're more bad than before. So
right. I appreciate that too. And some of the patients that I've provided care to is that even though their hemoglobin goes up to 11, they say they have profound fatigue. So it would be interesting to understand what's really driving that fatigue, because the hemoglobin's improved, so it's not just the hemoglobin.
It's really not related to anemia. It's fatigue and pain and musculoskeletal pain. They can't localize the pain, but they say, I just have pain. And I'm actually trying to stop the luspatercept in this patient to see if they feel better with transfusion without treatment.
Right. Thank you.
Very nice presentation. I think in the lectures this week, we'll be hearing more about magrolimab and some other new options for patients with low-risk disease. Have you had any experience using some of these newer compounds here?
Which?
Magrolimab?
No,
I'm
not
covering that.
Yeah, oh, you are?
Yeah,
okay.
I'll be covering
Even in
that.
low risk?
Not for low risk, but
Okay.
the general principles behind magrolimab treatment.
Well, that'll be great, because there was a low-risk trial with magrolimab in combination with azacitidine that we participated in, so it'll be interesting to share, that information. That's a, potential option for patients down the road as well in low-risk disease.
Yeah, we need more treatments.
We need more treatments.
Yeah. Thank you.
Thank you.
So let's move to the next presentation. Yes, it's you. It is Sara Tinsley about the management of the patient with higher risk MDS.
Hi, everyone. Thank you so much for inviting me. I'm very excited to present on higher risk myelodysplastic syndromes, or neoplasms, as we've just heard Sandy talk about. And I think these are my disclosures. This is a really difficult group of diseases to talk about, because we know that even among our higher risk myelodysplastic syndrome patients, they can look different and present differently. So what is high risk MDS? Well, we're learning there's lots of different ways, lots of different buckets to put patients in. So it really depends on which prognostic model you're using. We have the IPSS, the IPSS-R, which is really the most frequently used model. But now we're going to have to learn how to use the IPSS-M. And we have intermediate for the IPSS-R, and then high and very high. And we have more categories now when we're using the IPSS-M. But there are common features across the different depending on which IPSS you use. The increased number and depth of the cytopenias, increased blasts we know are not good. The more blasts we have, when I talk to patients, the worse things are getting. And it usually correlates with the blood counts are getting worse as well. And we know complex cytogenetics and certain deletions of chromosome 7 or pieces of chromosome 7 and our 17p deletion. So even though we can look at the different prognostic scoring systems and put them into each one of those, if you look at them, you will find that some of these things are pretty similar between them. You just have to add on to what you learned before. And then the mutation testing, really this is where everything is going. And I've been doing this long enough that this has evolved during my lifetime, the ability to detect these mutations. And I'm not sure because I'm very sheltered. I've been at the same location at Moffitt Cancer Center for many years. And we're doing mutation testing on all patients diagnosed with MDS or suspected MDS. But it would be interesting to me to see how many centers and parts of the world don't really have access to mutation testing to know how this can be really implemented in our prognostic scoring systems. You'll find 6 risk categories: moderate, high, and very high risk is how we would group the mutation testing. TP53 is non-binary in the IPSS-M. It includes allowance for number of TP53 mutations. We also have FLT3 and KMT2A, which is a mouthful. And then Sandy also provided this in her presentation, how to get to it, and that you can actually plug the information in and it tells you what it is instead of having to memorize that, because I don't think I could do that. And then how about the ICC? That's the International Consensus Classification of Myeloid Neoplasms, which there's been a lot of discussion about. Remember, it's a classification system and not a prognostication system. And as we heard, it lowers the threshold for AML diagnosis to 10 to 19% MDS/AML, so thinking more of the diseases along a continuum because they share common features. When you have a higher risk MDS patient, they're really a lot more like our AML patients if they have AML defining cytogenetic abnormalities. It is a classification system, so it's similar to the World Health Organization, and we talked about increased blasts as that adverse feature, and then how to incorporate it now into our MDS world. Really thinking of them, like I said, along a continuum. These are serious bone marrow neoplasms. They're life-threatening, and then how do we talk to our patients? You know that this is serious, and then talking to them about what their goals of treatment are, and do they really understand what they're being diagnosed with, and you know, where do they see this fitting into their life? What are their biggest concerns? And so these are some questions that were posed in a paper by Chen Wang and Dr. David Salmon, Therapeutic Approaches for the Management of Higher Risk MDS, that was in leukemia and lymphoma. So you can see it causes us to scratch our heads a little bit, like, okay, we have some competition here, the way we think about things. And so how many patients have higher risk MDS? About 87,000 new cases of higher risk MDS diagnosed worldwide. I'm sorry, 87,000 cases of MDS, and about 1/3 to 1/4 of those are higher risk disease. 75% of our MDS patients are older, have advanced age, 60 plus years of age. That's hard to hear for me as I get older and closer to that age. But many of our older patients are not able to undergo potentially curative therapy with this allogeneic hematopoietic stem cell transplant. And this factors into complex decision making. And one of my big pushes is making very personalized, individualized treatment plans, not like if you have higher risk disease, you get this treatment and you go on to transplant. You know, like really looking at that individual patient, looking at their comorbidities, their frailty, their quality of life, and seeing what do they value most when they start down this treatment path, this journey with their new diagnosis. As Sandy talked about this is something that we're really looking carefully at, frailty and comorbidity. There is a study that's in the references there looking at frailty. We know it increases our healthcare costs. There was this 15-item frailty scale, and when that was added to the IPSSR, it really helped us predict the individual patient's overall survival. So when you incorporate that at the individual patient in front of you level, it helps you provide the better information so that they can make a more informed decision. And also for comorbidities. For me, I think it's difficult to know. We have different tools for measuring frailty and comorbidity. So what's really the best tool to use for that setting? I know in one of my studies, I used the Charlson Comorbidity Evaluation looking at predictors of quality of life in high-risk MDS and AML. And for that particular study, the Charlson Comorbidity Index did not really separate for quality of life. I know it can for survival, but when I'm looking at quality of life, if you're looking at predictors like which treatment will give you the optimal quality of life, then that's something that we need to think about. Which tools really measure best what we're trying to get to, what we're trying to understand. So I'm very interested in health-related quality of life because many of our patients are not just interested in living longer and not feeling better. They want to have a better quality of life. When I ask them in my study, what are your goals with treatment? We know that health-related quality of life, or quality of life in general, is a broad, multidimensional concept. It's not just one thing. Fatigue is one of the big factors that goes into quality of life. And so it's very subjective. It's at the individual patient level, what they think is important to them, and then what is most affected by their new diagnosis. So quality of life in MDS, this is a study or a systematic review, which is a type of study, and they looked at quality of life in MDS and how it's been measured and what are some of the problems when we're trying to measure quality of life. You can see there were 112 different patient-reported outcome measures or tools for measuring quality of life in 168 published MDS studies. So when you think about that, you can't really compare one to the other if they're using a different instrument to measure it. Survival is more straightforward. It's a yes or no, that you're alive or you're not alive. But quality of life is more complex, and so measuring it also is more complex. And I think that is really limiting our progress and improving quality of life comparisons when we try to talk to patients about when the doctor talks to them and recommends a treatment, they leave the room, and then the patient looks at me and says, well, How is this going to make me feel? What's my quality of life going to look like? It depends on which study you look at and which tool you used. So the most frequently used cancer-specific patient-reported outcome measure from this review, these were the EORTC, QLQC30, and the FACT-AN for anemia. And there were other generic measures, the SF36 and the EQ5D. And then most studies dealing with myelodysplastic syndromes have reported that, like you heard earlier, and I think we can appreciate in working with patients, that the lower the hemoglobin levels are and the more red blood cell transfusions they need on a regular basis, that has definitely been associated with a worse quality of life, health-related quality of life. So we can say that with confidence. And some MDS treatments have been shown to improve health-related quality of life, and significantly with statistical tests, particularly among those patients who respond to therapy. But unfortunately, the majority of those studies were underpowered, and they were not included in the final label for the drugs. And then we did see that for azacitidine versus best supportive care in randomized controlled trial, this did show a significantly greater improvements in 5 of 10 scores for azacitidine-treated patients, and that included fatigue, dyspnea, physical functioning, positive effects, and psychological distress. And you can see the p-value there, and then the references there below. And then decitabine treatment was also associated with improvements in patient-reported quality of life parameters. You see the self-reported fatigue and physical functioning. It was assessed at random assignment and then every 6 weeks and the end of treatment. The EORTC QLQC30 was used to measure that, and that was a mixed model with a variable covariance structure comparing treatment between the two arms. I'm really very focused on patients' goals of treatment that they identify along with their healthcare team or their caregiver. And so it depends on whose lens you're looking for, and you can see the different goals and how they differ between the two, whether you're looking from the patient's perspective or you're looking through the healthcare provider's perspective. This is our treatment backbone: AZA, decitabine, and oral decitabine, and cedazuridine. And then we have magrolimab and azacitidine that's available for our patients on clinical trials at this time. It's going into phase 3 studies. This is the anti-CD47 antibody, the do not eat me signal. It's also on the red blood cells and overexpressed on the malignant cells, and it allows the macrophages to detect the cells. So when we use magrolimab, then that signal is turned off, which allows the magrolimab to engulf those cells and, eat them and cause apoptosis or cell death. And so it's being used in combination with azacitidine on a 7-day, every 28-day cycle. Overall response rates are about 75%, with complete response rates of 33%. You can see constipation, anemia, thrombocytopenia have been reported. And then I have the nurses' roles listed there. So close monitoring in the beginning, because the hemoglobin in the patients that I've provided care to and in the studies can drop pretty significantly with those first few treatments. And we even have taken the stance of transfusing them to a higher threshold before treatment, knowing that they can drop pretty significantly. So the nurses in our clinic and myself really watch those hemoglobin levels closely to keep the patients at a safe level, and helping set the patient's expectations that we anticipate that this can be a potential side effect, and then making sure that they're showing up for their lab checks and and for the clinic visits to make sure they're doing okay, and this continuous discussion of their goals of treatment and monitoring for side effects. We also have the CPX351, which is the liposomal daunorubicin and cytarabine. You can see the French MDS group has a phase 2 single-arm study, 52% complete response rate reported, and then the U.S. study, there was an overall response rate of 78% with a complete response in 4 of 18 patients. And there's really no randomized clinical trials at this time comparing HMA with CPX351 that we have results of. And we have sabatolimab and HMA versus placebo in HMA. And so between these two, this study was reported at the last ASH that statistical significance was not found between these two arms, although there was progression-free survival that was better with the sabatolimab in HMA, 11.1 months versus 8.5 months for placebo plus HMA, and studies are ongoing, but that did not reach statistical significance. And then on the right there, you see the nurse's role in patient management, safe administration of this investigational agent, helping patients, educate them on their neutropenia, thrombocytopenia, febrile neutropenia and anemia, and then constipation, diarrhea, which the diarrhea was like a surprising finding to me at about 44%. And there was one immune-related, potentially immune-related adverse event that had a fatal outcome. So really monitoring patients for that. And we did go through some of these. I just want to pull out the differentiation syndrome and how it's really important to be able to identify that and start the treatment with steroids quickly. And then venetoclax-based regimens. Sorry, I'm running out of time, so I'm flying through these. And then for the venetoclax-based regimen with quality of life, they used it was exploratory, they used the EORTC QLQC 30, and of the patients who received the ven, 400 milligrams, 14 days of a 28-day cycle in combination with AZA, they did find that physical functioning was maintained through 48 weeks of treatment, and there was clinically meaningful improvement in fatigue and dyspnea beginning with cycle 5 and maintained through week 48. So final results to come as the data matures. This was very appealing to me to be able to discuss some of these results with my patients. And then transplant. We know it's the only curative therapeutic option, but you really have to be careful which patients it's their goal and that are really the best transplant candidates depending on their disease characteristics and the patient's characteristics. We know that they don't have as good of an outcome with certain karyotypes, the complex karyotype and TP53 mutated patients. And for most of our patients, I would say this is a limited treatment option. And these are some nursing considerations in high-risk MDS. This is a publication looking at the animated patient guide to MDS, U and MDS that's provided by the MDS Foundation. It demonstrated a wide reach, has a vast potential to improve understanding of the disease, the diagnosis itself, and outcomes. And in the patient interactions, if you can refer your patients to the MDS Foundation website and consider using this on a regular basis. We do know that more research is needed that incorporates comorbidity, frailty, and quality of life into our current prognostic models so that we can engage patients and tell them the full story, you know, like this is what your quality of life is going to look like and this is what survival could look like too, so that we can have a pros and cons approach to making shared decision that we have enough information to provide to them. And then this is a virtual meeting that I'm involved in, and the public is invited. And there's a link there. It's 2 days, virtual, May 16th and 17th. And then these are just new concepts. And then thank you. Sorry, I went over by 32 seconds. So I'll take any questions you have if we have some. Or we can take a break if there's no questions.
I have one.
Okay.
Do you give venetoclax to all your patients with increased blasts?
Do we give venetoclax to all of our higher risk MDS patients? Yes. No, we don't. We do not. It is something that's very interesting. It's not on label. So some of it depends on, if they're frail and we're concerned about them after they break through and are no longer responding to azacitidine or decitabine, then this is something that we have added on and seen some responses, but it's not the standard of care for us to add it. How about you all?
No,
Where you are? No.
The same thing, but we just have azacitidine for the moment in France. So when we have young people with a transplantation project,
right,
sometimes we add.
Trying to get them to transplant. That was one thing. I was rushing through them because I had too many slides, I think, is that you can see the response as early as 1 cycle when it's combined with azacitidine. And we know that it usually with single agent HMA, it takes time, like 4 to 6 treatment cycles to get a response. So that's just the discussion with the patient. Do you want to be cured and you want to get a transplant, even if you might, if things might not go well, you still want to go to transplant, or do you want to kind of take a slower approach in day-to-day and not really go to transplant? But that's looking at the whole patient, their support system, comorbidities, frailty, yes. Iron, how they tolerate treatment. It's not a one-size-fits-all. It's I would advocate for a one-on-one decision-making and improve as much information about the patient that and then also factor in those clinical variables.
Yes.
Sara, really nice presentation. My head is swirling with questions.
Thank you.
The AZA-venetoclax combination, I'm sure you're using that. We find this to be a very, I don't want to say toxic regimen, but you really have your hands full when you have a patient with an oral chemotherapy agent.
Right.
That can be given either 7 days or 14 days or 21 days, and how the nurse's role is so critical to yes. communicating and educating them when to take it, when to stop, yes. because they have that bottle in their hands, and
right.
It's a worry. It's definitely a worry on nurses' minds to yeah. make sure you make that phone call. So I don't know how you're managing your patient population on some of these newer oral chemotherapy agents, because the nurse's role is so pivotal to caring for them safely.
Yeah, I think you have to watch them very closely. It's kind of like in the decision-making model that I'm building with patient data, it's AML, but in the prior study I did high-risk MDS because I saw them as a continuum, very similar. You can't over-monitor them, I think. It's just like, it's not, I divided treatment intensity into high intensity is like the CPX 351, and lower intensity is considered HMA and VEN in my current study with AML. But is it really, it's pretty intense as far as the type of problems patients run into are very similar mm-hmm. as intensive treatment. It's like some facilities, I think, still admit patients for HMA and VEN because the infection, bleeding, transfusions are very similar between the two.
Hemolysis.
Yeah, I totally agree.
Right.
And when you transfer that all to outpatient management, you have a whole nother picture because you're relying on those caregivers and patients who don't feel well to try to be actively involved in their care, which is, it's hard to be on your game when you feel sick.
Exactly.
Yeah,
and
thank
so
you.
your precision medicine, I think that's so critical when when you were speaking about the lenses to look at from the patient's perspective, the science behind why you want to give a particular therapy and have them come on board, with that treatment plan, to be part of the decision, be part of their management with their caregivers. So the conversation with the nurses be directly with the patient is quite often very different when the physician is there. The physician leaves, and then I have 25 questions to go over, and I don't know if I can do this. So you really need, where do you get that time as a nurse now to be spending with these patients and educating them through that whole conversation of treatment and care and transfusion? So
yeah, I appreciate that perspective a lot. So I think some of the answers are, the MDS Foundation has this wonderful tool that you could buy some time by starting it and then timing yourself, or you could go do something else. While that's animated, it's very engaging, and it kind of walks through telling the patient about their disease. And so then you could time yourself and go out and do something else and come back in and then ask them, hit the high points, see what they understood in that video. But thank you. All right, thanks very much.
Are there any questions online? I don't know.
No.
Okay.
No.
No questions. Okay, thank you.
So we have to take a break. 15 minutes.
Everything's good. Okay.
Good.
2 minutes late. Passion. I can tell it's my passion.
Ah oui, tu crois? Second part of our workshop with Jacqueline Dubow and the patient perspective.
Hi, everybody. First, I would like to thank you, the MDS Foundation, for inviting us. I think this is the first time since this Congress exists that a patient representative is doing a presentation. So that's a first. Where should I? Which button should I press?
The green.
The green?
Yes.
Okay. So I'm going to present you the result of a global survey that was done by the MDS Alliance. I'm the chair of this MDS Alliance, which is a network of 40 MDS associations worldwide, and we are covering about 30 different countries, the largest one being the US and Canada, then several in Europe. And in Asia, we have Korea, starting Singapore. We don't have China. We hope to be able to work with China. And the goal of the MDS Alliance is really to help the MDS associations to get stronger, more professional, and to also to help in terms of access, because access to drugs is so know, I mean, the gaps are so huge from one country to another one. Some countries, like Kosovo, for example, just a blood transfusion is difficult to get. So that's what we are dealing with. 2 years and a half ago, we decided to do a global survey with MDS patients. This has never been done. It was a first. Okay, no disclosure. And yeah, I just told you about the MDS Foundation, the MDS Alliance. We are a steering group of 9 people, 4 in the US, the rest, the 5 of us, 6 of us, depending how we are counting, are in Europe. And this study was done by SES in the UK, and the funding came from BMS. And BMS was supporting the study, but never participated to the study. So we were totally free. So what we wanted to do was to better understand and raise awareness of people living with MDS. And we tried to do that to make it evidence-based. And why evidence-based? Because we want to improve and help improve the access to care. So how the survey was done, it was the data were collected between November 21 and April 22, and we used our network of members to get to the patients. So each patient signed a consent form, and the survey was translated in 10 different languages. And that was new, because when a global survey are done, very often they are done only in English. And of course, not everybody is speaking English. So here we try to make the effort to translate that in at least 10 different languages. So the way it was done, it was administrating the questionnaire. We created the survey plan. We worked on the research question. We developed the survey. We pre-test the survey, and the survey was translated in 10 languages. So here you have the list of the different questions that were used. Just to be fair, we are the working group within our steering committee, and Sandy Kurtin was the PI of the study. So too bad that she's not here today. We divided the question in 9 areas, and it was a long process for us, because we wanted to cover everything, and that was a complication. So the final survey ended up in those 8 different sections. First, demographics, then disease history, the current status of the patient, what was the overall health of the patients, mental health and well-being, of course, quality of life. For the quality of life, we used the QALMS that was translated in 10 languages, if I'm correct. Then access to care, effect of the COVID, and improving quality of life and access to care. So the participants, the way we reach the different patients was each member organization received details on the survey, and this was translated in their own languages, and they were requesting to their members in country to fill out the survey. So what the MDS global, the steering committee did was to receive all the details of the survey, and this was shared on social media in order to increase the reach and the distribution. There was also a social media campaign, including Facebook, Instagram, LinkedIn, and Twitter channels. And those are working quite well, we must say. And we had a specific page created on our web to help people to link to the survey. So, survey completion, we had 65%, which is fairly good for a survey. We had over 900 people who started to fill the survey, and then at the end, only 509 completed the survey. But it was a good result, especially, I will come back on that, due to the fact that the survey was fairly long, over 40 minutes. And that's way, way too much time. So that's the first lesson we learned. But 65% was a good rate. Here you have the completion rate per country. Some country did very well, some country, I mean, the country that did the best is South Africa, but there was only one respondent. So depending on how you use the data, you get something different. You have to notice that most of the respondents were from Canada and the US. So there is a big imbalance in terms of respondents. So demographics of the respondent, most of them were living in urban area, 68.6% in urban area, 31.4% in rural area. In terms of the ratio female-male is pretty correct, a little bit more females, 56% than male, 42%. Yes, what was interesting was the level of education, because what is quite striking is that most of the respondents have a fairly high level of education. And that's a big lesson for our associations. We are reaching the people who are the most educated, and the people who are the most in need, we don't reach them. So there is a big effort to be done. So keep in mind that respondents for that survey were people who were fairly well educated. And you can notice that 27.8 had higher education, at least master or doctoral level. So in terms of disease history, the median was 3 months between symptom onset and a diagnosis. So this came as a surprise because we thought that generally the delay is longer. So, of course, 62.8% of the respondents reported fatigue before diagnosis. It's always the same main factor. So what kind of test was done prior diagnosis? 96% blood test, okay. Bone marrow, 89%. Chromosome genetic testing, 36%. Flow cytometry, 17%. And molecular test, 9.1%. So overall, the testing is quite good. In terms of risk level and subtype, 53.9% of the respondents did not know their IPSS risk level at the time of diagnosis. So keep in mind, again, that it's patient-reported. So at the time of the diagnosis, maybe they were told their risk level, but they didn't catch it. And 29, almost 30%, did not know their subtype at the time of the diagnosis. And quite interesting, some people, it's almost 6%, learn about their risk level and subtype by doing their own research. But the majority of the people did not know. So in terms of treatment, respondents, 52% are going through blood transfusion, 45% through EPO, and 14% went through a bone marrow transplant. 20% don't have any treatment. So that's a striking figure here. 74.8% have never been contacted, told about a clinical trial. So here we know the difficulty to recruit for clinical trial, and here, when you ask patients, almost 75% have never been asked for a clinical trial. So what are the patient perspectives to improve the quality of life and access to care? 10%, almost 11% are saying nothing. I'm going to the end of this graph. Exercise, 2.8. So being a patient myself, I know that when there is fatigue, you are told, try to walk. But look, not even 3% of the patients are going through exercise. On the other hand, knowledge is important. And what people are asking for is less fatigue, less fatigue, less fatigue, less fatigue, whatever the cause of the fatigue is. They want more treatment option, but it's a fairly low number, you know, it's 8.5. Only 5.7% are looking for a cure. You could think that the cure would be at the top. No. Insurance-related, only 4.8, but this can be explained because most of the patients were living in the US, where the health insurance system is very different from most of European countries. Financial support advice, 3.4, so it's not a huge number. Some people don't know. Some people would like some help. And some people were bothered by the COVID, 2.8, but I will come back on that. Another, yeah, it's just amazing because if you look at the bottom of that graph, MDS Center of Excellence, only 1.2% of the patients don't care, either because they know that's possible, but it's at the bottom of the list. And here what you have, integrative treatment, holistic care, it's 2%. So this is coming more and more, and I think those numbers should be coming. Stem cell transplant, only 1.2%. And this number doesn't fit with patient reunions, because earlier there was a patient session, and most of the question, I mean, over 50% of the question were about stem cell transplant. So here, through the survey, we don't get this type of information. I mean, the numbers are much lower. The COVID, not so much important for the patient. And this can be explained that MDS patients are quite careful, and they are experiencing a lot of fatigue. So the confinement was not very different from what they are living regularly. So, in conclusion, we can say that most of the patients are tired of being tired. Fatigue, fatigue, fatigue is always coming back. I looked, because we are still looking at the data from the survey, something quite interesting. The people who are expressing the most the fatigue are the people who have the highest income. So I don't know if we can generalize, but it was interesting to get those numbers. There is a need for better communication between patients and healthcare providers. Here, nothing new. This was discussed earlier. I think there is still a lot of effort to be done here. Some patients ask help from their doctor, but help was not always forthcoming. And when you need help, you need to knock at the right door, and the doctor may not always be the right person because he's busy. I mean, there are many reasons, and the nurses are very often the best point of entry. Information at diagnosis, people would like to have more understandable information because the lingo of the hematology field is really complicated and completely incomprehensible. You know, the first time you hear about hematopoiesis, even if you've studied Greek, you said, what the heck is that? And you get lost. And it creates a barrier. And very often, I mean, in the past, I was a linguist, and you can feel that for some MDs, it's easier to protect themselves through a very scientific language. But for the patient, it's really difficult. And this came quite strongly along the survey. Clearly, information and participation on clinical trial needs to be addressed. And that's where patient association can help, because they can be the bridge between the need. And also, and it's coming more and more, and the literature is also showing it, clinical trials are creating a bubble where patients needs to be the perfect patients. And when you see at the heterogeneity of the MDS patient, this doesn't fit. And then, after the clinical trial, if you see that, for example, luspatercept works with 42% of the patient, in real life, the numbers are much lower. So, information about clinical trial, but also trying to have clinical trial that can be decentralized and that can be more aware of real life data is important. Access, I talked about that earlier. The gaps between countries in terms of access is huge, and this needs to be addressed. And as a patient organization, we are working a lot with pharma company to try to address this issue of access. And last, but recurrent question, less frequent blood transfusion. Thank you.
Thank you very much, Mrs. Dubow. We are very proud that you have made the first patient presentation in this session. And it was very interesting to know, and we know that that patients need more time, and often physicians are so busy now that we could not give enough time. You have a question? Just time for one question, because there is 5 minutes.
Do you have a way that you have thought about for meeting those other people that aren't the well-educated, you know, to close that gap between the disparities?
Well, it's about...
Is there a good solution?
It's about health inequalities.
Yes.
So in the US, it's a huge problem.
Right.
And in Europe, it's also a problem, but with another difficulty is that in Europe, we can ask people the color of their skin. We are not allowed to do that. In the US, it's very easy, it's normal. So that's a barrier. And I think patient association needs to have much more funding, need to work more with clinicians, because the clinicians, I hope, are seeing those patients.
Right, we definitely are.
But this has to be put within the context of health inequalities.
Right.
Because you are going to see that in all disease.
Yeah, it's complicated.
To see that 75% of patients haven't been offered a clinical trial that's a large number, and I think it's trying to get the message to patients for them to feel comfortable to have that conversation with their physicians and their nurses, to ask those questions. Sometimes they're very intimidated, afraid, they don't want to be disrespectful, but it's for them to find their voice, right, and be really engaged in their care. But as we were just talking about with the diversities that we see there and the inequities, those are real problems across the globe. How do we improve those measures there for patients?
There are cultural differences. I mean, I spent half of my life in the US, and I can see that culturally, patients in the US are going to ask questions. In Europe, it's less the case. The doctor is still the guy who knows, and I'm not going to ask anything because he's the guy who knows. And this may also be linked to the fact that in the US, STEM, I mean science, technology, and mathematics are more spread. Kids at school are following much more those scientific curriculum than in Europe. So people have a mind that is more science-oriented. But there is a huge difference between patients in the US and patients in Europe. Some patients in the US are going to the doctor like they are bringing their car to be repaired. I'm a car, fix me. That's not the attitude in Europe. And if you talk about less developed countries, it's less and less and less.
Yeah, I agree. There's a big push for shared decision-making. But with the shared decision-making, our job is to try to understand the patient's perspective, not necessarily have them understand everything we're recommending, but trying to understand what their goals are when they're getting treatment, you know, like what's most important to them. But I can see it's a process, you know, and change is very slow.
Oh, and by the way, we are going to redo this survey every 2 years, and as an incentive, countries that will be able to give 100 patients will get the raw data for their country.
That's good to know.
Thank you very much. So let's move to the last speaker, Mrs. Demakos, about building resilience and work-life balance.
Thank you, everybody. I'm going to be talking about building resilience and trying to have a work-life balance as nurses and caregivers of patients that are very sick and very complicated. So it's a round out to our discussions today and seeing all the data that's been presented and the complexities in the care of these patients. It is very overwhelming, and we have to remember to check in with ourselves, and make sure that we're balancing things out appropriately. I have no disclosures. At least within the United States, pending COVID crisis, the great resignation, people in healthcare are really deciding to walk away from the healthcare practices and do something else in life. In 2020 alone, they say 18% of the healthcare workers have quit their jobs, and a good percentage of them have decided to do something else rather than healthcare. And according to surveys that are out there, and this is obviously ongoing, indicating that 20 to 50% of U.S. physicians and nurses are already planning on leaving their jobs within the next year. So some of the drivers, of what they call the Great Resignation is really the work overload, and amongst nurses and physicians and caregivers in general. It's just the time-pressured environments that we're all being faced with in caring for these patients. It becomes longer hours. In the United States, at least, there was a big strike in New York, and I think some of the biggest drivers for nurses was the inadequate nursing staff levels, and the patient ratios were very high. And considering to be unsafe. They didn't feel like leadership was listening to them. Is the hospital leadership within their own organization understanding the pressures that they're facing, which will lead to burnout. And we're going to talk a little bit about compassion fatigue and burnout. So coupled with all those variables, it's leading to the lack of control that we might have over our own practices that we're involved in, and it includes nurses on the inpatient floors as well, caring for these patients in bone marrow transplant and oncology floors. It's just the organization within the system that's become broken in many facets that impact on us not being able to care for our patients in the way that we want to. Insufficient reward. That's another one, professional recognition. Not like, oh, you're doing such a great job, but really, the day that we're facing, how much stress that we're under, and not, again, leadership not maybe potentially understanding those facets that we're facing. Lack of professional development opportunities for nurses. Nurses want to continue their education, and they want hospitals and leadership to help support that at a much higher level. Being undervalued and underpaid. That was another part of the strike, at least in the United States and across the United States in general, about increasing pay for nurses. So we talk about burnout versus compassion fatigue. And burnout these are the descriptions of them and the definitions, which are different, but they can be overlapping. Burnout is a psychological term referring to general exhaustion and a lack of interest and motivation regarding your work. Whereas compassion fatigue, also called vicarious trauma, refers to the negative emotions that individuals feel from helping others. They can feel the same, but different. Burnout, you really feel frustrated and angry, with the institution or where you're practicing. And compassion fatigue is that we're not doing enough as nurses for our patients, or at least that's the sense that we feel when we can't get to everything that we need to do. So here we go into compassion fatigue in terms of just the cost of caring. It's the mental and the emotional distress that can follow. And just having just negative attitudes after a 12-hour day, a 10-hour day, still leaving thinking that you haven't accomplished everything that you want to do, or did you give the best care that you could provide to your patient. Exposure to trauma, grief, and suffering, these are causes. Lack of support and resources. With COVID and in general and in healthcare, the resources are very limited. You take on multiple roles now. Less staff that's available to help assist in the clinic is not there anymore, so you're doing a couple of job descriptions right now. And this really leads to a very poor work-life balance in our lives. We physically become exhausted. You're dehydrated because you're not hydrating enough. You have headaches. You're not sleeping. I mean, quite often, more than not. I have lists upon lists that I have to remember that I need to do, or maybe I didn't do, and I want to be reminded that as soon as I wake up to do them. So it's like your brain never shuts off, and causing a lot of anxiety. And, you know, sadness. And this really can result in you becoming even less productive because you basically were going to a fight or flight response and shut down. And so, you know, you have to check with yourself, when have you felt emotionally depleted, and what have you done in those responses, and how can we improve that for ourselves? And so as I go through these slide deck, these are just tools and helpful you know, options that we can try to implement within our lives. So burnout is the syndrome characterized by the feeling of emotional exhaustion we talked about. When you look at depersonalization, the depletion of empathy, caring, and compassion, everything that we stand for, why we became nurses, why we want to help patients, and feeling that frustration of just you haven't accomplished what you needed to do. And that, to me, is very overwhelming. I've experienced that multiple times. And we need to learn how to take care of ourselves so we can take care of others. Causes of burnout, we just talked about. It's the workload, job demands, lack of control and autonomy, social support, poor organization, culture, and communication within our own organization, and just a difference in balance. So we need to check in. How often have these statements felt true to you in the past year? I feel less enthusiastic about my work than before. I become insensitive towards patients or colleagues, family. I become more callous over time in my current role. I've heard that from many of my colleagues recently. And I can't remember why I wanted to become a nurse. And what concerns me with that statement is that I hear that in the younger nurses. You know, Sandy is not here, which is sad. Sara, you've been doing this for a long time. I've been in the field for over 30 years. And when you hear that from a colleague that is just starting out, maybe 5 years in the profession, already feel this burnout and compassion fatigue, and they're questioning why they went into nursing. So how do we build a compassion, resilience, in achieving a work-life balance? I'm going to go through these individually, but it's really, again, the process that requires constant check-ins with yourself. I probably don't practice half of these. I try. We all try. But it's a reminder. Sometimes you have to have those Post-its. You have to have things right in front of you to remind, to say, I give myself permission to take care of myself. And it's hard for us to be able to do that. So it starts with drawing that, you know, line in the sand, setting the boundaries between work and personal time. I struggle with this all the time, and I'm sure many of you do as well. And it's just something that you need to give yourself permission and say that you deserve it, and you need to. And try to really define your work hours and try to stick to them. which is very difficult because, again, you want to do your best job that you can. So when you're in the clinic or you're on the floor caring for your patients, you still have a whole list of prior administrative responsibilities and duties that you need to take care of and do. You're going to exceed your work hours. Communicate your boundaries with your colleagues. Check in with your team. Try to really work together as a team and say, I need your help. Can you give me a half-hour lunch break? I need to walk away. It's a nice day. I need to just walk away for a little bit. Ask your colleagues and the physicians that you work with and express what your needs are. Because when you do that, you work better as a team and you're taking care of yourself at the same time. Again, taking care of yourself physically, mentally, emotionally, and spiritually, whatever your needs are. Getting enough sleep, we never get enough sleep, or your brain doesn't shut off. And you're sleeping, but you're thinking. There are times, and I'm sure you're all feeling that as well, that you're sleeping and you got Post-its in your head, and you're thinking about the things that you have to do. You're not having good dreams. You're having actually nightmares. Eat healthy meals. Really think about how you're, feeding your own body. And again, engaging in regular exercise, whatever that might be for each person. Just taking a walk makes a huge difference. Taking the breaks during the day, and prioritize self-care as a non-negotiable. We make our patients, show up for clinic appointments, make an appointment with yourself, and practice self-care. Because when we do that, it's really benefiting us both physically, mentally, spiritually, within our team. We work better, we have less stress, and this is really, really important to overall wellness. Consequences, we know we're healthcare providers that, they see this through multiple reports and data that there's more sick time. And you are less productive because you become so overwhelmed that you do literally shut down and are not as effective. This leads to the compassion fatigue. Manage time effectively, really learning how to be well organized. And that's a difficult task because there's priorities and then there's new priorities. And then your number 1, 2, and 3 become 5, 6, and 7. And you mentally need to figure that out and adjust your sails, so to speak, and understand that you're not going to be able to accomplish everything, and that's okay. It's not that you're failing, but again, trying to remove the negative thoughts in your head is difficult, but try not to overcommit, not always say yes to everything. And try to lean on your colleagues to maybe help in that and say, this is a project that's important. This is something that we want to do. Why don't we work together? Divide and conquer. Important. Foster supportive relationships. So important to make sure that you are staying connected with friends and family and colleagues in the moment. And again, that's really hard because your mind is probably thinking of other things and you're not enjoying life yourself. So make sure that you have, you're building a nice little support system that's close by that you can check in so that you can help maintain that work-life balance. Again, it's not an easy thing to do, but really, really important. Practice mindfulness, be present in the moment we just talked about. Paying attention to the present moment without judgment. Be kind to your own mind. Really understand that you're doing the best that you can, you're showing up, you're caring for very sick patients, and you're caring for your family members, and you might be caring for your parents. So you're working, you're caring for patients, you're caring for your parents and your other family members. It's a lot to balance out and juggle. Taking breaks and vacation time. Really difficult. I think last year I barely took any vacation time, and it was just because of lack of staffing and people not around. And I wanted to make sure that I was doing what I needed to do, but it's just not a healthy thing. So you really have to try to incorporate that into your plan. And again, work with your team. Making sure that everyone is taking their time off and covering each other, I think, is really important. And it is difficult, but it can be managed if you work together. It's the only way that you're going to be able to walk away from work and be able to heal your soul, your own mind, and take care of your own physical well-being. Learn to delegate. I have a problem with delegation, but you've got to try to learn to delegate tasks and responsibilities. Again, outsourcing to your little colleagues and your other friends to help you, I think, is something hard for me to do, and probably hard for many of you to do, but we need to learn how to try to do that better, because, again, it will balance out for everyone if we each help each other out in that way. And, you know, make you feel better about coming into work and leaving at the end of the day, maybe not so late, maybe on time, maybe a little bit earlier, so that you can be engaged in life outside of work. Flexibility and adaptability. Embrace flexibility and adaptability with your work. You're not going to be able to accomplish everything that you want to in that particular day, and try to figure out what plan is going to work best for you will change on a daily basis. It's a constant thing in life. There are always ups and downs, but try to be flexible and reassess your own needs and the needs of your team that you're working with and the needs of your patients, so that you know that you cannot get to everything or every patient 100%. So try to understand that in your own mind, which is be kind to your mind, forgive and move on, forgive yourself. You have to take ownership of that and say that I've done the best that I can do. And we have a hard time accepting that when we feel like we're failing our patients, not being able to make all the phone calls or spend as much time with them, whether they're in the clinic or inpatient, but to just remember yourself. And so it's a constant self-talk, you know, to yourself. Talk out loud, say things, write down Post-its, have affirmations. Whatever it is that's going to, you know, help you, you figure that out, is the most important thing, I think, in our minds, because we're very hard on ourselves as nurses in general. Make time for joy. Where can you be creative? Think something outside of work.
Erin, I'm sorry. The timer is wrong, and you just have 1 minute more.
Oh, wow.
Sorry.
Okay. All right. Thank you. Okay. So make time for joy. Meditation, mindful breathing. Breathe. Breathe in 4. I'm going to do that right now because I got like freaking 1 minute. 4, 7, 8. No, so you inhale through your nose, 4 counts, breathe, hold for 7, and then breathe out. It's definitely very helpful. These slides will be available, so I'll just kind of cruise through these. Create your own toolbox. Many resources out there for nurses and for this presentation that I have. Look up what the 5 love languages are, so that you know who you can connect with on a deeper level, which is really helpful. What kind of person are you? How do you thrive? And it's said that we can't attain enlightenment, let alone feel contentment and joy, without seeing who we are and what we do, without seeing our patterns and our habits. This is called developing love and kindness and an unconditional friendship with ourselves. So we have to be kind to ourselves. And Brene Brown has got wonderful resources and podcasts if you want to listen to her presentations on a lot of the self-love. And thank you.
Thank you very much. It was a very, very nice presentation with a lot of ideas for improve our real life.
It's hard.
Thank you.
Okay, thanks.
Thank you. So the workshop is finished, and we have to move to the next session. Thank you, everybody, to be with us.